Hi, my name is Vincent. Today, I would like to introduce pre-diabetes or diabetes counseling case in NAC OSCE exam. So there could be two types of cases. The first one is, as you can see, counseling the patient who has already been diagnosed and visited the clinic for follow-up. In this case, we should evaluate and manage the patient's current status. In the second case, as you can see, the patient visited the clinic with the first diagnosis or has pre-diabetes test results. In this scenario, you will focus more on explaining the diagnosis and management. We can approach these cases by properly opening up, like other scenarios. The second part is the history taking, and if it is the follow-up case, we will also take a focused history of the patient's diabetes management. After that, we will counsel the patient. I will introduce the ICE format to open up the counseling and mnemonics to explain the diagnosis and also management of diabetes. I will also review the Diabetes Canada guidelines to prepare post-encounter questions. I will assume that everybody already know how to open up the scenario, so I will introduce about history taking from now. Before taking the patient's general history, we should take the patient's diabetes history. In the pre-diabetes scenario, we should ask for the test to be validated and check if the patient fasted before the test. In follow-up cases, we should check the type of diabetes, diagnosis date, and medications, including compliance and side effects, especially if the patient uses insulin or sulfonylurea. Also, we should check if the diabetes is controlled and if the patient gets the proper checkups. After that, we can ask the patients about general symptoms that might be related to diabetes. I always like to ask questions from head to toe, starting with whole body symptoms. First, we will check the patient's body habitus, changes, and general symptoms such as tiredness, frequent infections, and delayed healing. After that, we will check for symptoms of retinopathy and neuropathy. We will check the patient's cardiac symptoms, such as chest pain or palpitation, and kidney symptoms, such as urinary frequency, thirst, frothy urine, and color or smell changes. Also, it is important to check the patient's sexual function since it highly affects the quality of life. Do not forget to ask about food ulcers too. After that, we will take the rest of the patient's general health as usual, but remind that asking specifically about hypertension and hyperlipidemia since it is important for further management. Also, checking if the patient is taking medications that can cause hypoglycemia is essential. Don't forget to ask for a detailed social history from smoking, alcohol, and drug consumption to lifestyle, including occupation, diet, and exercise, since you should counsel patients based on this information. Now, if you took the patient history, it is time to counsel the patients. I will introduce how to open up the counseling part. To open up the counseling, first use the ICE format. I means ideas, which you can ask for the understanding of the patients, and C means concerns, which you can ask about the patient's specific concerns. Last, E means expectations. You can find out what the patient hopes to get from the consultation. Also, we should explain the diagnosis if it is a pre-diabetic or first diagnosis scenario, or if the patient has limited knowledge about diabetes. I use mnemonics and WCPM, which can be easily remembered by the sentence, normally we can probably manage. N stands for normal anatomy and physiology, W stands for what the disease is, C stands for the cause of the disease, P stands for problems and complications, and M stands for management. Let's follow the mnemonics to explain diabetes to the patient simply. When we eat food, the stomach digests it and makes glucose, which is sugar in the blood. At the point, the pancreas makes insulin to help blood sugars enter the cells. However, when someone has diabetes, they have a problem with insulin function. So, blood sugars cannot enter the cells and fill up the blood vessels like traffic congestion. There are two types of diabetes. Type 1 is someone who cannot produce insulin because of a genetic problem, and type 2 is someone who loses the insulin function because of this. When you eat bad foods that constantly increase your blood sugar levels, the pancreas is fed up and produces less and non-functioning insulin. It leads to further sugar increase, which exhausts the pancreas more. This is the vicious cycle that leads you to diabetes. When you get diabetes, increased sugar and congested blood will damage all your organs. It causes heart attack, stroke, vision loss, kidney failure, foot ulcer and amputation, and reduced immune and nerve function. After that, you can advise the patients about management. First, please tell what patients can do. Patients can change their lifestyle by healthy diets, which avoids foods high in sugar and fat, and regular exercise, 30 to 45 minutes of moderate exercise for 4 to 5 days a week. And if the patient is smoking, guide them to smoking cessation, and also emphasize the importance of tight glycemic control to prevent further complications. Educate patients about the symptoms of hyperosmolar coma or diabetic ketoacidosis to prevent emergency situations, and also educate them importance of avoiding hypoglycemic status if patient is using insulin or sulfonylurea. Also, encourage them to check their blood sugar regularly by writing down the sugar note, and if the patient is using insulin, lead them to check their blood sugar 4 times a day before meals and bedtime. Also encourage good food care and regular podiatrist appointment, and explain them possibility of missing wounds by loss of sensation. And then you will tell them what you will do. You will do regular checkups to screen for diabetic complications, and also regular blood tests to check blood sugar levels, and counsel on starting medications such as metformin or other medications, including insulin, and also manage any complications if they have or as they arise. Please remember the treatment targets for diabetic patients. You should aim the glycated hemoglobin under 7, fasting blood sugar level from 4 to 6, LDL under 2, blood pressure under 130/80. Now I will introduce about possible post-encounter questions. First of all, you have to learn the criteria of diabetic screening. Who is aged more than 40 years or have high risk should be screened every 3 years. Someone who has very high risk factors should check their blood sugar levels by every 6 to 12 months. To screen the diabetes, you will use fasting plasma glucose level or glycated hemoglobin level. Next is the diagnosis. If the patient has fasting plasma glucose more than 7 or glycated hemoglobin more than 6.5% or more than 11.1 in glucose tolerance test, or random plasma glucose over 11.1. If patients one of these numbers, patients should have another confirmatory test to be diagnosed with diabetes. Except for symptomatic patients with these numbers, they can be directly diagnosed with diabetes without confirmatory tests. For management target, we should aim under 7% of glycated hemoglobin, but it could be adjusted following the patient's status. For example, if the patient has limited life expectancy, we don't strictly aim 7% to prevent the hypoglycemic crisis. For medication options, we can start metformin whenever we want, but especially for the patient, if patient has more than 1.5% of A1C level above target level, we should start metformin immediately. And also, patients has a symptomatic hypoglycemia or metabolic decompensations such as diabetic ketoacidosis or hypersomnolence syndrome, we should initiate insulin right away. If patients cannot attain target A1C level, even though they use the metformin, we should consider adding additional anti-hyperglycemic agents based on patient's medical status. For example, if the patient has clinical cardiovascular disease, we should consider SGLT2 inhibitor or GLP-1 receptor agonist, which proved to be effective for preventing cardiovascular disease. After that, we should check every 3 to 4 months if they attain the target A1C levels, and if they doesn't, we should consider adding another agent. Also, we should start medications for cardiovascular protection. For example, if the patient has macrovascular symptoms such as cardiac ischemia or peripheral artery disease, we should starting with ACE inhibitor or ARB with aspirin. Also, if the patient has microvascular symptoms such as retinopathy or neuropathy, we should starting with ACE inhibitor or ARB. Also, we should know about the common side effects of diabetic drugs. For example, metformin has a side effects such as GI disturbance, vitamin B12 deficiency, and lactic acidosis. And for sulfonylureas, it can lead to frequent hypoglycemia and weight gain. Also, SGLT2 inhibitors can lead to frequent UTI and diabetic ketoacidosis. Thanks for listening to my presentation, and I wish you all the best.